Welcome back to part 7 of our Explainer series. For all the CPCs, auditors, and clinical documentation specialists tuning in, you know exactly why we're here today. We are cracking open the auditor's rulebook to decode the notoriously confusing Chart B of medical decision-making. You know, the one focusing on the amount and complexity of data to be reviewed and analyzed. If you've ever found yourself staring at a chart, second-guessing whether a test counts as one data point or two, well, you are definitely in the right place.
Here's a quick look at our compliance survival guide for today. We'll be hitting Chart B's structure and tiers, decoding tests and documents, defining unique tests and sources, looking at independent historians and interpretations, discussing management, and finally, rounding it all out with some common auditor pitfalls.
All right, Section 1, Chart B's structure and tiers. Let's start right at the foundation.
As an auditor, I always map Chart B out like a grid in my head, exactly like this. Across the top, you have your 4 data complexity tiers: minimal, limited, moderate, and extensive. And driving those tiers, that's your 3 distinct core categories of data. Category 1 is all about tests, documents, and independent historians. Category 2 handles the independent interpretation of tests, and Category 3 covers the discussion of management or test interpretation. Think of it like a giant sorting hat. Every single piece of data you review absolutely must fit neatly into one of these 3 buckets.
Moving on to Section 2, Decoding Tests and Documents. Let's dive deep into Category 1.
So the real linchpin here is the word analyzed. The guidelines state that ordered tests are presumed to be reviewed when the results are reported, which means they count toward the MDM in the exact encounter they're ordered. But, what about recurring orders? Well, tests ordered outside of an encounter, like future or recurring orders, are counted in the encounter where they're actually analyzed. Take a monthly prothrombin time, for instance. Each new result counts in the subsequent encounter where your provider actually sits down and analyzes it.
And that brings us to a massive, unbreakable rule in medical coding, a total auditor pitfall, the absolute prohibition on double dipping. Simply put, if a provider bills for the professional component of a test separately, you cannot count that same test towards your MDM data. No way, no how. You either get paid for the interpretation via the CPT code, or you get credit for it in your MDM data. Never both. All right, Section 3, Defining Unique Tests and Sources. Let's get into the actual mechanics of counting. First off, what exactly is a unique test? Well, it is defined strictly by the CPT code set. A clinical laboratory panel, say a basic metabolic panel, code 80047, is a single test. You absolutely cannot unbundle a panel to get more data points just because it happens to test for multiple things. If the CPT code set defines it as one clinical panel, it counts as exactly one unique test, period. Let's compare a couple of everyday scenarios to see just how strict this uniqueness rule really is. Say a provider compares serial measurements of the exact same code during a visit, like multiple serial blood glucose values. That still only counts as one unique test. On top of that, tests with overlapping elements are never considered unique. For example, a CBC with differential includes the hemoglobin, a CBC without diff, and a platelet count. Because they overlap, they are not unique tests, even if they have completely distinct CPT codes. Don't fall for it. So, what about a unique source? When your provider is reviewing prior external notes, a unique source has to be an external provider from a distinct group practice or a completely different specialty or subspecialty or a unique healthcare facility. And here's the real kicker. Reviewing all materials, literally no matter how many pages they send over from that one single unique source, only counts as one single MDM element. Next up, Section 4, Independent Historians and Interpretations. This is the human element of our data. An independent historian is required when the patient themselves just isn't able to provide a complete or reliable history, or maybe when a confirmatory history is medically necessary. This could be a parent, a guardian, a surrogate, a spouse, or even a witness. The crucial detail here is that they are providing history in addition to the patient. But listen, the actual identity of that historian matters immensely to an auditor.
Here is a classic documentation trap. A parent, a surrogate, or a medical caregiver, they absolutely count as an independent historian because they're providing medical context. But a language translator, nope, they strictly do not count. A translator is really just facilitating communication of the patient's own history. They aren't acting as an independent source of historical medical data.
Shifting gears to Category 2, we have the independent interpretation of tests. This only counts if the test has a CPT code. where a formal interpretation or report is typically expected, and it was actually performed by another physician or qualified healthcare professional. Crucially, your provider has to document their own independent interpretation of it. And, tying it back to our earlier rule, they absolutely cannot be billing for that service separately.
All right, Section 5, Discussing Management and Results. Let's talk about the interactive exchange. Discussion of management, or test interpretation, requires a real interactive exchange with an external physician, another qualified healthcare professional, or an appropriate source. This is a high-level professional exchange, guys. It cannot be passed through clinical staff or trainees. It has to be a direct, peer-to-peer exchange regarding the management of the patient.
Interestingly enough, the definition of an appropriate source goes beyond just doctors. If it's directly relevant to the patient's medical management, an appropriate source can be a non-healthcare professional. We're talking a lawyer, a parole officer, someone holding power of attorney, a case manager, or even clergy. But, and this is a big but, it generally excludes informal family caregivers. They would fall under the independent historian category we talked about earlier instead.
Finally, Section 6, Auditor Pitfalls and Key Takeaways. Here is how you keep those charts audit-proof.
Let's quickly recap the biggest errors we see out in the field. First, never double-dip separately billed tests. If you build it, it doesn't count for MDM data. Second, you can't unbundle or count overlapping CPT panels as multiple unique tests. One panel equals one test. Third, language translators are never independent historians. And lastly, your internal practice colleagues in the same group and specialty, they are not unique external sources. Honestly, you might want to keep these 4 rules taped right to your monitor.
Now that we've rigorously defined all these raw data elements, the tests, the documents, the historians, the discussions, we actually need to know how to add them all up. So join me in Part 8 of our Explainer series, where we are going to start scoring these elements into actual combinations. We'll look at exactly how many unique tests or sources it takes to hit minimal, limited, moderate, and extensive data complexity.
This framework is absolutely crucial for getting the reimbursement your providers deserve while staying completely compliant. But I want to leave you with this. How many data points are currently slipping through the cracks in your practice's documentation simply because they weren't counted correctly? It's something to think about. Until then, keep your documentation clear, trust the rulebook, and decode healthcare with Harshal.